We want to have a conversation now about the health of our lungs. TB. And the person who's joining us is Dr. Sam Muga. He's the Deputy Chief of Party for USAID Tamatisha TB program. Dr. Muga, good morning.
Good morning.
How are you doing?
I'm doing well. I'm glad to be here.
Your cousin, Dr. Muga, here,
Muga CT,
has been waiting for you to come.
Yes.
So that he tells us, finally, how you're related. So, City, go.
You know, when you insist as much as you've insisted, surely there must be a reason behind it.
Surely, Bwana.
Okay? Now, this is something that needs time to be told. So immediately after the show, my cousin and I will explain to you how we are
related.
Yes, we'll explain.
Because some,
yes,
there are not many Mugas that you come across in life.
There are quite a few.
Okay.
You can count our family.
Well, see?
Exactly
That's
my
the point.
Exactly. When you count them, they're in your family.
Yes. Yes.
Karibu sana to
Thank you so much.
conversation. That's a hot seat of the situation room. You'll tell us a lot about the program that you're running and why it's important that all of us focus on it.
Yes.
But Dr. City Muga will give us the day's proverb. And the job of Dr. Sam Muga is to listen and give us the interpretation of that proverb.
Yeah. All right.
Yes, our proverbs for the whole of this week come from the state of Libya. Okay? Yes, an interesting country, this one. Very, very interesting. By the way, the name Libya in very, very ancient times was actually the name that was used to refer to the whole of Africa.
How ancient was that?
Where clearly none of us was alive then, and we hadn't even been thought of.
Those guys only knew Africa from the Mediterranean to the end of Libya.
Well, they called it Libya because...
That's what they knew.
Yeah, that's what they knew. Because remember, the countries of the Maghreb are very close to Europe.
Yes.
Yeah.
Okay? And it's the Europeans who came up with this nonsense of colonization, remember? Yes.
So when they crossed over the Mediterranean, they go to Libya.
They go to Libya, or they go to Algeria, or they go to Tunisia.
This was even before they knew Egypt.
A long time ago.
Aye.
It's a long time ago. Egypt is not part of the Maghreb. Please remember that one.
Yeah, but it's in Africa.
Point made. Point made. Point made. Point made. Point made. All right. When the turban moves, there moves the territory.
When the turban moves, there moves the territory.
Yeah, I think this means when the critical core moves, the catalytic core, the rest of the annexed appendages move also.
Okay.
Yes.
I better say that in English.
So there are things if you touch.
When the critical catalytic core moves, the rest of the appendages.
Don't worry, I'm an Odiero, so. Yes, so
Sorry, man.
Sorry.
So when you touch the important parts of something or a situation, it then makes the rest move. I'll give an example related to TB. So we are, for example, focusing on key things that if we touch, make a difference. Like now in the country, we are focusing on 16 deep focus counties. 16 deep focus counties are the ones that carry the high burden of TB in the country. And if we change that, we are bound to change the whole country. That's 47 counties. And that's just an example that's relevant to our discussion today.
Move that turban.
You see, we were in the Muga. The Muga thing.
Yeah.
It's DNA.
Yes.
It's in the DNA. That's a good one.
Thank you.
It's a good interpretation of it.
Yes, thank
Asante sana. So, like you said,
Yes.
there's an issue with TB in the country,
Yes.
and there's concerted effort. One of the people who would have joined you for this conversation, and she's been unable to join us, she's unwell, and we wish her well, is the acting head of the Division of TB and Other Lung Diseases
Yes.
at the Ministry of Health, Dr. Immaculate Kathure.
Yes.
So there's something that's being done by government and partners in addressing TB in Kenya.
Yes.
Why is it such a big issue?
It's a big issue because TB is still a big problem, and not many are aware that it is a problem. So most of the population, for example, if you get some respiratory or lung problem, it's likely that the first action you take is probably walk to a chemist and pick some antibiotics and get some sort of treatment.
Yeah.
But that can be TB, and it can affect anyone, any age. So that awareness is important, that respiratory problems can be TB, and it needs to be looked at. The other challenge is that in the country we seem to be not identifying as many that are required. So like in 2023 we had about 97,126 cases, but the anticipated is 124,000. So we are falling short of detecting, identifying and treating the cases. The other problem that is there is drug-resistant TB. So when I say drug-resistant TB, is that now TB sugu, drug-resistant TB that now is resistant to one or more of the drugs that we use for treatment. And we also still have a big challenge in terms of detecting that in country. And actually we are doing a drug resistance survey so that we can be able to identify how widespread that problem is, and also be able to look at that in terms of now allocating resources to be able to detect drug resistant TB a little more. So it's a problem. So you're dealing with drug sensitive TB that people don't know about, and we are probably just treating that by the regular antibiotics. And we also have drug resistant TB that there are people working with it out there,
Right.
and
many don't know.
And many don't know. And for example, our children are not immune to this. So TB also affects children, and so childhood TB is also an agenda that we are also trying to deal with in the country. So yeah, those are the issues.
Okay.
In addition to that, there's stigma. So those who have TB and they are being stigmatized and put aside, and that's a whole new agenda. Yes.
When we look at TB in Kenya, tuberculosis, are we looking at it across the country, or are there certain parts of the country where it's more prevalent than others?
So across the country, So it's everywhere. But definitely there are areas of higher burden, right? Where more cases have been identified, where more cases need to be identified. And those are the counties I was speaking about, the 16 deep focus counties that our USAID Tamatisha TB through the Center for Health Solutions Kenya are trying to focus on and invest a little more so that we can make things better.
Okay.
Yes.
I mean, at the risk of sounding flippant, why is it such a big deal, TB? Why? And this is good, I think, because by way of explainer, that why such deep focus on this disease? Why is it such a big deal?
So first, it's ancient. It's a slow killer. It's smoldering just below the surface, but taking away many lives, right? And without that advocacy, without bringing it to the surface, it's likely to be ignored, and people don't give it the necessary focus. I'll give an example. When we had COVID, the hullabaloo was about COVID, which is quite acute. But you see, TB was still there. And it is very easy to, if you're not so keen, to confuse those respiratory symptoms and say, hey, likely COVID, but TB needs to also be ruled out and make sure that we invest in the same. So yeah, the advocacy is needed. It's quite something. Yes.
What's the difference between TB and other respiratory diseases?
TB and other respiratory diseases, it depends with first the causative agent and how it presents. So the causative agent is mycobacteria, tuberculosis for TB. There can be other causes of respiratory illnesses. This would include viruses and other bacteria. But the presentation tells you whether this is TB or not. So you have cough of any duration. You're likely to have weight loss. You have night sweats at night. You have loss of appetite. You can have a cough that is productive of sputum with some blood stains in it. And as we know, TB, it affects any part of the body except the nails, the hair, and the teeth. So you can even have TB of the skin, for example.
Okay.
Yes. And so
does it start from the respiratory area and then spread to the skin?
Yes, most likely, yes.
Okay.
Yes. It starts off from the respiratory area, then spreads.
Is it easy to pick out?
Yes, it needs a keen eye, someone who has that eye to pick out the symptoms. But further, there is assistance to use diagnostic approaches. So you can go into the lab, your sputum is looked at, and there are some particular tests that are carried out. They're called molecular diagnostic tests. And now, in country, we are also piloting artificial intelligence that has been put into chest X-ray machines. So with this, you're able to image the chest and be able to have artificial intelligence assist you to quickly screen for tuberculosis, and then you can have subsequent tests. So that makes it better.
When I ask about how easy it is to detect, it's because of what, like you said, you have a cough, you're feeling some type of way, you walk to the nearest pharmacies, and you ask for antibiotics, or you ask for something, and you're given something by the person that you find there. Are they well equipped to be able to detect and say, no, this one could be TB? Like, is it possible for you to go to a pharmacist and you'll find the farm technician or the pharmacist that you find there, or you go to a health facility and the clinical officer or the nurse that you find, as soon as you present yourself, and then they just ask you 3 questions and they can tell this likelihood TB?
Yes, with the symptoms I have shared with you.
I'm coughing. Okay.
Yes.
Yeah.
Cough
I'm
of any
sweating at
duration.
night.
Yeah, I'm sweating.
It is hot season, Dr. Muga.
The sweating is quite profuse. It's not the one like you've walked. That is causative. You have walked under the sun. It's hot. I mean, you can relate that. But you're sleeping at night and it's persistent, and you're also bringing in the other symptoms of your coughing,
Weight loss,
your unintended weight loss. That can be intended. Going to the gym, you're fasting or something, but unintended weight loss, I think, is the right way to say it.
Productive cough.
Productive cough.
Maybe blood in the sputum.
Yes.
Okay.
Those are quick things you can pick up. And with that, you can be able to, move in the direction of testing for TB.
Okay. So, maybe this would have been a question that came before, but I think still at the same time. So what is it exactly, this tuberculosis that we talk about? What is it? I mean, from before, that, okay, maybe it's caused by bacteria, but where do you get it from? Somebody coughs, who has it? Can you get it from somebody else? But we saw that COVID, they told us don't, it could be on the surface, it could be, aerosoled. And then if you're in, direct contact, you touch without washing your hands and such. So where do you get it from, and how can you prevent yourself from getting it? Do we do the same thing? Do we wash our hands? Do we make sure that you're not in? How would you know that somebody who's coughing around you has it? What is it?
All right. So TB definitely is a disease, and it's spread through the air. So we say that anyone, when you sit close to anyone who has it, whether they cough, talk, or even sing, they are able to pass those droplets into the air. And then that person who is not infected now inhales it, and it goes and sits in the lungs, and now it's able to cause now those symptoms that we have spoken about. What do you exactly do to prevent yourself? So now it's important to have infection prevention practices. So cough etiquette is one of them. Just making sure that those aerosols or droplets that come from coughing, singing, and talking are not transmitted to the next person. So it means the distance issue is still important the way we had it for other respiratory diseases. Making sure that you are in rooms that are well ventilated, right? So airflow is a big item.
Yeah.
So having your windows opened, because these aerosols, they hang around for people to inhale them, and this includes our public transport, our houses, our classrooms,
Yes.
and schools are important. Those kind of things. Still, the other items of washing your hands are important, because once you cough, you're still able to have them on the surface. But mostly, airflow, the distance, and also being able to know who is this who has the symptoms, so that they can move in for treatment. The other way, putting it on the flip side, treating those who have the disease itself is important, because it prevents transmission. So they need to complete their treatment and just make sure that as they do that, they are also taking care of those who are around.
Okay, so that's why it makes sense then, what you said earlier, that there are certain areas where you'll find that the prevalence is higher. So if you connect that with what you've said about, areas where there is little to no ventilation, and if you look at places where living spaces are cramped, would you then say that you probably then, if tuberculosis was resident there, then it would be of a higher prevalence than where there is, better ventilation and where living spaces are spaced out more?
Yes, so I would say that is one of the social determinants or social drivers of the transmission of tuberculosis. There are others.
Okay.
Tuberculosis is also closely associated with malnutrition.
Okay.
Yes. So children and even the adults who are affected by TB would need nutritional support. And we also look for TB in those who have malnutrition, particularly in the children. So there are those social determinants, just as you have mentioned, that are drivers for the transmission of TB.
Okay.
Yes.
You know that you're here, Dr. Now we are going to be coughing. We just... Oh my
Yes,
God.
that is cough etiquette.
Sasa daktari wa TB yako hapa sasa atafikiri. Now, your elder cousin here has worked for many years in that space of healthcare, in the HIV care and treatment. I'm sure he's interacted a lot with matters of TB, and so he'll have a couple of questions before he comes in, because all of you Mugas are in the healthcare space. Right? What is the Tamatisha program?
So the USAID Tamatisha TB is actually a cooperative agreement. When I say a cooperative agreement, it's an award from USAID, whose prime recipient is the Center for Health Solutions Kenya. Center for Health Solutions Kenya is local indigenous organization that aims to serve communities with innovative, well-formed approaches to address public health problems. So USAID Tamatisha TB is a mechanism. It's a national mechanism that supports a national TB program that Dr. Immaculate leads to address the problems that are related to TB. And the aim is to accelerate TB control in the country towards some targets. In the 5-year period, we are aiming to achieve reduction of mortality and incidence of TB in the country. Yes.
Okay. I've heard a couple of times when somebody has coughed for a very long time and they're not quite sure what the issue may be. How do you know when it is time for you to actually go and have it checked out, number one? And is it easy to screen? I don't know if that's a good question. Is it easy to get the results or to know from a test, from screening, that this is actually TB?
Yes. So I mentioned cough of any duration. Cough of any duration. That should spell the urgency that if you start coughing now, don't wait. Don't wait and say, yeah, I'll wait a couple of days and observe.
See if it goes away, kind of thing, yeah.
So, I mean, it puts in that that need, that willingness and proactiveness to address it early and make sure that it's checked.
Okay.
And then the ease of screening now has become easier. First, from the symptoms we have spoken about. I mean, it's a four symptom, kind of screen and say, hey, I've been coughing, this sweat, it's productive, and I'm losing weight, so let me, get checked. But now when it comes to the health facility, for example, there are other things that have made it easier for the healthcare workers to be able to identify this. So in addition to the screening approach, there's what now I mentioned about artificial intelligence that has made it really robust. So you can have an image very quickly and it looks at your chest, and then you're taken to now the lab where your sputum is looked at and you're able to be diagnosed quickly.
Yeah.
So with this molecular and AI-assisted technologies, it has become much easier for us to be able to identify TB. And we are scaling this across the country to improve access and just to make sure we are able to reach marginalized populations. Yes.
Can children get it?
Yes.
Babies?
Yes.
And so when is it too early to then be able to test if you have a baby, for example, who may, if we're looking at now areas where, again, ventilation is not, adequate, and you don't have enough, of course, now air passing through, and if there's a baby in that particular area, when would you know then to cough duration of any time, but when would you know then to test for a child? Especially now when you're looking at when babies are born, the tendency is to wrap them up because, you don't want them to get cold, kind of thing, and they've not yet sorted out themselves. How would you then be able to look at a child, for example, and know? Because then we have these young children who are growing up but could be at risk.
So TB in children would present with more severity than in adults because the immune system is not as strong.
Yes.
And that severity would probably present like, failure to thrive, as we call it. It may be attendant with some malnutrition in it. And then the other symptoms may also present, but in some form of severity because of that immune system I mentioned. But the most important thing to pick out is that they get it from an adult.
Okay.
So it might be the mother. And so the mother needs to have that sensitivity to know that, I can you can see that distance if you, for example, either breastfeeding or you have the baby close and you're coughing, you're probably passing that to them.
Yeah.
The other way is that there is an adult who probably visited that household and they have symptoms of TB. They've been coughing for a while, and maybe it's a visitor. You just place them in a room somewhere with a child, and they're able to transmit. So yes. Now there are also advances to be able to identify TB in children much quickly, and these are largely guided by the symptom screening we use, or I have mentioned, in children, but also that particular history that they have engaged with an adult who has the symptoms, and then just transmitted to them. Yes.
Still on the issue of testing, I think there's a more direct question here. What is the gold standard for testing TB?
So the molecular test is what we call GeneXpert. So this is a polymerase chain reaction test, amplifying
there you go,
DNA, amplifying DNA of the bacteria itself. So we pick that from a sample and you amplify it and say, hey, yes, this is right here. And out of that also we can check for resistance for other drugs.
Okay.
Because after you amplify the DNA, you can compare it with a template and say, yeah, there's resistance. in this particular strain, in this patient, and then you can tailor the treatment.
That's a gold level.
Yes,
we
that's
call the top level. And the basic one? The most basic one, is it just those 3 questions?
Basic testing, the symptom was screening. So testing is that you now do microscopy. So you if you remember microscopy, you take the sputum, put it on a slide, and then you check it out, and you stain the bacteria and see, I can count them and say, this is positive, and then you initiate treatment. So that's at a basic level. Okay. Now we are moving to the more advanced detection modalities, so that we can be able to detect more cases.
And faster. Yes. So the other question is, how long does it take normally to treat TB?
Yes, so you take 6 months.
6 months?
Yes.
Of taking medicine?
Yes.
Daily?
2 and 4, yes.
And
so an intensive phase of 2 and then...
2 months intensive and then 4 months?
Yes.
And what is this that's not intensive? How many times a day? How many tablets a day?
All right. So it depends. This is tailored according to weight, age.
Right.
Yeah, but it's really a very convenient way. You can take it once a day, depending on how your tablets and the strength of the tablets look like. Yes.
Why so long?
Mycobacteria is tough. It's a tough bacteria to deal with. It has a coating. It has... it's somewhere in the body, and it has defense mechanisms. So you have to give these drugs in a way that enables them to penetrate, and this takes time.
It's armor-plated.
Armed. So it fights back, essentially, is what we are saying. That we're looking, if we're going to get into some of the details, that for it to understand, because folks are saying, you know what, and as we've heard people who have said, well, I've started taking the TB medication and I feel better. The cough has subsided. Look, I'm going to chuck this thing. I'm done.
Stop sweating.
3 months I've been swallowing this thing. I'm feeling better. The cough has gone. But are we saying that it's the same thing as with any other antibiotic? That if you do not finish the course, the likelihood of the bacteria to say, okay, well, they've stopped fighting. I can come back stronger and manifest myself greater in the body. Are we looking at the same thing?
Oh yes. And believe me, for TB it's tougher, because now you get into drug-resistant TB. If you have exposed the bacteria to the first-line treatment and you have not finished, now it comes back with vengeance, and now the treatment would go even longer, because then you're dealing with tailoring a medication for drug-resistant TB.
As far as diseases go, this is an old disease.
Yes, it is.
As the 24th of March is when some German figured out that this thing is actually caused by bacteria.
24th of March. I was going to say 2020. Okay.
Yeah, well, the 24th of March is my birthday, so that's why I remember it.
And that's World TB Day.
Yes.
And that's when we celebrate it countrywide.
Yes.
Worldwide, actually.
Yes.
Yes.
But the thing is, it's an old disease, but the question has to be asked, why is it so difficult? With all the advancements we've made in science, in treatment, why is it so difficult to eradicate?
So, when you introduce the human factor into disease control, you then have a challenge. So, stigma, the education that is needed. So like what we have just spoken about, I'm feeling better. I mean, I don't see the reason to continue.
Yeah.
I mean, that takes us back. We are now speaking about their preventive mechanisms, their medication we have put out there for prevention. But surprisingly, it's very hard to convince someone that take this preventive medicine, it will prevent you from getting TB. They say, I'm not feeling unwell. I'm okay. Why should you? Yeah, and more so even with, for example, healthcare workers who are working in the risky situations where you have the TB patients. Tell them, take this preventive medicine. But it's tough. So when it comes to an individual decision and the mentality of a person and the human factor in there, it's a very fluid situation.
This health-seeking behavior that we have and our understanding of ailments and treatment. Because it appears we seem to believe, I'm talking about us Kenyans, us Africans, is that the moment you start feeling better, you're okay.
Yep.
And feeling better doesn't mean that you are actually,
Exactly.
yes, you are just feeling better. Because the idea, perhaps more so with men, the idea of seeking healthcare is when you're unwell. And unwell for most men, you're on your
You're
on your deathbed.
Bed.
You're about to croak. Yes, exactly. So how do we go about treating this? Because if that could be managed, if we could change people's attitude and behaviors towards treatment, these many problems that are caused.
I think the that's one area where the media fraternity can help us quite a bit, because with the messages you send out, you're able to influence health behavior and be able to basically tell people that, look, this is something of concern. You need to act. So that health education approach and advocacy approach, I think, makes a big difference in alignment with the interventions, the diagnostic, treatment, prevention that we do now at hospital level or at facility and community level. The advocacy I think is really, really critical.
So there are prevention mechanisms for a myriad of diseases that the globe faces, and a lot of that is vested in vaccination. And we do see a number of bacterial infections, bacterial diseases that do have vaccinations. And a lot of the campaigns also for ending diseases, Tamatisha, to end tuberculosis. For the other some of the other campaigns for diseases that we see, it's really insistent on vaccination. Polio being one of them. Smallpox was another one. So leading to the question, is there prevention mechanism in vaccination for tuberculosis? Because like CT said, and like you said, it has been there for ages. Is there talk around vaccination for prevention?
Yes, so there's quite a bit of talk around vaccination, and maybe the context to start off from is we have a TB vaccine called BCG.
Yes, which babies take at
Bacil
birth.
Camlet urine. So the one that you have on your arm
On the day they are born,
yes, and then it forms a scar
A
that
scar.
you remain with for the rest of your life. So this vaccine reduces the severity of TB, but for a limited sort of span of time. So as you grow older, you still are at risk of getting TB, and developing disease. So what is going on right now around the vaccination space is there's a lot of research to be able to find more effective vaccinations towards tuberculosis. So for now we are using what we have, the BCG one.
Yes.
But we are also, in addition to that, exploring, other modalities. So looking at scenarios that if we get a vaccine, fine, it would help us. But in addition to that, are there other modalities? So treatment, better diagnostic, so that you are having a multi-pronged approach to the control of tuberculosis.
So one of the problems that we suffer from, I think, is data and numbers. If there is a particular demographic to be looked at to say that we can be sure, and say for looking at the arm where you have that scar, right, that the certain percentage of the population did get the BCG at birth, because usually on the day they'll come yank your baby, go do the shot, right? But how can we be sure that a certain number of the population has actually gotten the BCG, so that we know that even if there has been an infection of tuberculosis, that the severity of it would be much less. Do we have that kind of data, those
yes,
kind of numbers?
I may not have those at the top of my head right now, but the Department of Dealing with Vaccination can be able to provide that. But beyond that, we are looking at numbers of those then who develop the disease. And the dynamic seems to be a bit different, because when I was speaking about 16 deep focus counties with high burden, let me give you Nairobi and Kiambu. We are likely to find that access for vaccination, working class mothers are probably in Nairobi and Kiambu. They probably go to private facilities. They have these high-end vaccination approaches, but TB is still there. It's a high burden. Definitely, the mix might be because the population is a mix of. There may be informal settlements, for example. There may be the working class and the high end. So it's a mixed dynamic.
Yeah.
So depending only on the vaccination data to draw a causative kind of link to the TB situation might not be it. There may be other dynamics and other social determinants that drive the picture that we see.
Okay.
So then in the Tamatisha program,
Yes.
because Tamatisha here means end. Tamatisha TB means end TB.
Yes.
Okay, so what are the timelines? What are the targets in terms of data, in terms of milestones, in terms of time? By when should we end TB?
Yes, so we are visionary and ambitious to support the national TB program to accelerate TB control, to end TB in Kenya by 2030. That means our award is about 5 years, just starting this year, but going all the way by 2029, we should see we are somewhere. And there are two key data targets that we're looking at: reducing mortality and reducing mortality by 90% and incidence by 80%.
Reduce
by
mortality by?
90% and incidence by 80% by 2030. Yeah. So we're working together with the country, and those would be country achievements. So it means you're working with other partners, you're working with the National TB Program and other stakeholders to accelerate that.
So what do we need to do then in the next 5 years in order to hit these targets?
First we need to work together.
Okay.
We need to work together. It's a collaborative approach. Apart from just having these innovative interventions that we put in place, everyone needs to put the hand on deck. So media advocacy, other departments, say agriculture, you need to provide nutrition for those who are struggling with TB. In health, there is, making a universal approach, primary health care kind of approach to support the various community persons to be able to engage. Interesting places like Ministry of Interior, for example, they need to support us in controlling TB, for example, in the prisons.
Getting the chiefs to talk.
Across the borders.
Okay.
Yes, that talking is important so that we really make a difference and advocate for TB control. So when you see someone coughing, support them to be able to access the treatment.
Daktari, those are not smart objectives. None of those is. I said, let's talk about increasing our nutrition. What do we need? It's 5 years.
All right. So
in 5 years, what are we saying? Are we saying that we should now have balanced diet for every child in Kenya in those 5 years? Are we saying that SHA, that we shall fund SHA to the tune that it can support primary health care in those 5 years? What are we saying?
I have given you processes, and I think you told me they're not smart. All right. Okay, so our objectives per se revolve around certain things. One, reach. All right. So when we say reach, we want to detect more TB cases and actively find them. So that's one. Two is treatment. And here we want to improve the treatment success rate. We are doing about 85%, but we want to go higher. So treatment success rate, what we were speaking about, you've started your medication, are you completing it, and have we controlled TB in that particular individual and in areas of interest? Then prevention, right? So we want to prevent this transmission, and there are these drugs we spoke about that we can give to prevent someone from developing TB, doing the infection prevention control approach, aeration, making sure that you're in spaces that transmission doesn't happen. That's prevention. And then sustain. And under sustain, we now have these collaborative approaches that I focused on, and I was told they were not very smart, but let me bring them out again. So building capacity at national level with the National TB Program, at county level, where we are working with the county governments and CHMTs and the various stakeholders and partners to make sure there's enough capacity at that level to make a difference for TB. So those are four smart sub-capacities.
Reach, treatment, prevention, sustain.
Yes, very good.
And now we measure those in the next 5 years.
Exactly.
And see how we are doing.
Okay. Yes.
Thank you very much for all the lessons that you've taught us today, Dr.
Thank you, Latiff.
Yep. So Dr. Sam Muga is a daktari in the Republic of Kenya, but also he is the Deputy Chief of Party for the USAID Tamatisha TB program. The target is to end TB in Kenya by the year 2030, working collaboratively between the development partners, supported by the government and other agencies on the ground. For example, this one you're dealing with the Center for Health Solutions in Kenya.
Yes.
Yeah.
This is the Situation Room, the only way to start your day.